Everyone, we'll go ahead and get started on chapter 35. This is the second video of this. We'll have three videos in this chapter 'cause it's a very long chapter. And so this one's probably, I would say, the most important chapter to really understand. This has probably the most important information in it about stuff that you'll actually see taking care of children. And so we jump into respiratory stuff. So respiratory problems are a leading cause of cardiopulmonary arrests in the pediatric population. Why is that? Because I've said it, children die from hypoxia. So, if the child's hypoxic, they're going to die. And so our resuscitation efforts, even in cardiac arrest, is aimed at improving ventilation and reducing hypoxia. And so hypoxia is what kills kids. Okay. And so in the early stages of hypoxia or respiratory emergencies, you may note changes in behavior. They can become combative, restlessness, anxious. And so it's really the same in adults as well, but that's something to look at. And so we've talked about the signs and symptoms in the previous video, but let's recapitulate. So nasal flaring is when the nares of the nose will flare open with inspiration. And abnormal breath sounds, so wheezing, rhonchi, all those things exist, right? Accessory muscle usage. Remember, in children, you're more likely to see accessory muscle usage in the subclavicular area, the neck. You'll see that very, very commonly. The children's intercostal muscles and their diaphragm are not near as developed as adults. So in respiratory distress, they'll rely more on those accessory muscles, not those primary muscles of ventilation, like the diaphragm and the intercostals. So you see a lot more accessory muscle use. With that said, children are more likely to become tired breathing and stop breathing or not be effectively breathing because their muscles are just not as strong. And so as a reminder of what the tripod position is, this is a, if I were to tell you to run to the stop sign and back and you grab your knees and you're leaning forward like this kid is here, right? That's what we're saying. That's tripod position, okay? So as a pediatric patient progresses to possible respiratory failure, remember failure is when the respiratory system fails, like it can't work anymore. The efforts to breathe will decrease. And so, if they're breathing 40 times a minute and you suddenly notice they're breathing 20 times a minute and now 10 times a minute, they're in respiratory failure. That's respiratory failure. They have failed. Okay. And so the chest rise, the depth, the rate, all this will decrease because those muscles have become tired. The body has used up all the available energy stores and cannot continue to support this extra work of breathing. So this is almost like running. If I were to tell you run as far as you can, you're going to start off running pretty fast and pretty strong, but at the end you're going to get slower and you're not going to be taking as big as steps, right? You're going to be really struggling. And so the same thing's happening with the same muscles in between your ribs, the intercostals, and the diaphragm, the muscles used for breathing. And so changes in behavior and eventually alter level of consciousness. Remember, the brain is very perfusion dependent. If it doesn't get what it needs, you'll see alter level of consciousness, alter mental status. Patients can experience periods of apnea. What's apnea? That's the medical word for not breathing, okay? And then so the patient, the heart muscles will become hypoxic and the heart rate will eventually slow. That's going to be a very late finding when the heart rate slows, but that will happen, but it's a late finding. Now, this is an important concept because we see this a lot. Respiratory failure does not always indicate that the airway itself is obstructed. So, a kid with asthma, no, that's not a good example. Well, yeah, sure. A kid with asthma doesn't mean that they have like an upper airway obstruction, right? They could just be literally in status asthmaticus or an extremis, and they're at the point where they just can't maintain their ventilatory effort anymore. And so that's actually fairly common. And so, I wouldn't say fairly common, but that's like an example of someone having respiratory failure, but it's not due to an airway obstruction like a battery stuck in the trachea or something like that, And so the conditions can progress from respiratory distress to failure at any time, so you want to reassess these patients frequently. One thing about children is they tend to compensate until they don't, right? So they'll be doing, okay, this kid's sick, they're really sick, yeah, they're sick, and then boom, they're crashing and they're about to die. So if you talk to anyone who's taking care of sick pediatrics, they'll tell you that, and it's a known thing in literature. There's a reason why, but kids will compensate until they don't, and when they don't compensate, they just fall off of the cliff and deteriorate very rapidly. Okay, so this is why you'd want to reassess them frequently. Okay, allow the patient to remain in a position of comfort. You would want to support their ventilations with a BVM at 100% oxygen. Remember, you don't need to squeeze the bag all the way. It's just enough to get chest rise and fall. Okay, and it's going to be at a higher rate. So like a 6-year-old, you're going to ventilate at 20 to 24 times a minute. Okay, you're not going to ventilate them at 12 times a minute like we would an adult. Okay, so you're going to ventilate them with a little less of a squeeze, just enough to get chest rise and fall, but at a higher rate. And so it looks like they emptied out grandma's purse here, but these are all things that kids stick in their mouth. So anything that a kid can stick in their mouth, they will. And so this creates this huge choking hazard. Coins, batteries, toys, candy, rocks, it doesn't matter. Kids will stick it in their mouth and they will choke on it. Okay, so be aware of that. Secondly, as I say, in case of trauma, teeth may have become dislodged and those can become stuck in the airway as well, and create an airway obstruction. And so blood, vomit, mucus, any of these things can cause saliva, even can cause airway obstruction. Okay. Now there's infectious causes of airway obstruction, and we're going to talk about each of these individually. But infection should be considered if the patient has congestion, fever, drooling, or cold symptoms, right? So they tell you, oh, the patient's been coughing, or they have a fever. Then you might think like, oh, this could lead to an airway issue, like an airway obstruction. And so like croup is the upper airway. It's a viral infection at below the level of the vocal cords. I'll show you what this looks like in a coming slide. And then epiglottitis is the actual epiglottis. So this is the vocal cords of a baby or a young kid. And so right here, these are the vocal cords, these white things. And so here's the glottic opening. And so this is what this is normally supposed to look like. But you can see how red and large and inflamed this structure called the epiglottis right here is. And so this can become so red and inflamed, it can actually occlude the trachea. And so if that happens, the patient's not going to be able to breathe and they're going to die. And so this is a bacterial infection that's called epiglottitis. We'll talk more about this, but that's kind of, you can imagine if this is swollen and covering the trachea, that's going to be an airway obstruction. And so this is what we're showing you here, right? This is the epiglottis. Normally when we swallow, it's supposed to flap over and cover the trachea right here and allow food to go down into the esophagus, the food tube. But when it gets very swollen, it can swell so much it can cover this this opening. In fact, it can get so swollen that it can make it to where you can't even swallow your spit, or it's extremely painful to swallow your spit. And so this is why you'll have the drooling. These patients classically present with drooling, okay, because they can't swallow, and they're even having a hard time breathing. And so the airway obstruction by foreign objects may involve upper or lower airways. So, this would make sense. If someone swallows a AA battery, that may actually get lodged in the child's trachea. But if someone, or say swallow, they inhale, they aspirate a AA battery. Now, if someone aspirates maybe a AAA battery, a smaller battery, or a button, or something like that, that may make its way all the way down into the bronchus, and it's going to go until it gets lodged. If you had to pick one of the two, if the trachea gets occluded, you will die very quickly. If you shut down a segment of the ventilation of a portion of a lung, you won't die from that, but it will create infection and someone has to go get it. But that would be the examples, okay? And so, signs of an upper airway obstruction would be stridor, okay? Remember, stridor is that high-pitched noise that you hear in the upper airway. That's stridor, right? And so, but wheezing, and notice that was on the inspiratory phase. You hear stridor typically on the inspiratory phase. But wheezing, on the other hand, is what you'll hear if someone, swallows that button or whatever, and it gets all the way down into their bronchus. That's a lower airway obstruction, so that's an obstructive pathology. So you're going to end up hearing wheezing. You might even hear crackles from the pulmonary edema from the body trying to respond to this foreign body in the lungs, okay? So know the difference between these two. This will help you get questions right on exams. If they tell you that there's wheezing, it's below the trachea. If they tell you that there's stridor, it's the trachea, okay? Remember, the trachea is the airway tube in the front. So the best way to establish breath sounds in pediatric patients is listen to both sides of the chest to armpit level. Remember, there's going to be bleed over because the chest wall is pretty thin. I talked about that. So immediately begin treatment of the airway obstruction. So you'd encourage coughing to clear the airway when the patient is conscious, and you'd want them to forcibly cough. That's very helpful at clearing the airway. But if this does not remove the object, do not intervene except to provide oxygen. Okay, the thing is, if they have a partial airway obstruction and they have the ability to cough, they're able to move air. And so you would not want to you want to do something crazy at that point. So you would try to keep them calm, keep them comfortable, and then take them to the hospital if they're still moving air, and you could apply oxygen to supplement them. But if there's severe airway obstruction, they will not be able to cough. Remember, the universal choking sign is 2 hands on the neck. And so they wouldn't be able to speak or cry. They're going to have difficulty uh, breathing with stridor. Remember, stridor is the upper airway noise that we hear. They could have cyanosis, which is the bluish tint of skin, and then loss of consciousness. And so eventually, if there's a complete airway obstruction, you're going to die. So in 3 to 5 minutes, they'll go into cardiac arrest. And so then we do full-blown CPR so let's say a kid's choking on food. They go and you get there. By the time you get there, they're in cardiac arrest. You just do CPR. Okay. If they're conscious, you can do 5 back blows. We'll show you. You did this in CPR class, and then you can roll them over and do 5 chest thrusts. Okay. And so if you want to use gravity to your advantage and keep the head at a low angle, to hopefully that food will shoot down with gravity towards the floor. Okay. If the child's conscious with a complete airway obstruction, you would perform the abdominal the abdominal thrust, known as the Heimlich maneuver. Again, you were shown how to do that in the BLS class. You could use the head tilt chin lift finger sweep to remove visible foreign body in an unconscious pediatric patient. That's interesting. I was always taught not to do that, but apparently they're teaching that. The idea is if you do a blind finger, okay, it's not a blind finger sweep. You can do a finger sweep if you see the object, right? So you see like, oh, there's a piece of steak. I could just like scoop it out with my fingers. You could sweep it out. But if you can't see in the mouth, like you just like they're choking, but you can't see it, you don't want to stick your fingers in there because you might just push it in there further. Okay. So you can do a finger sweep, but it's not a blind finger sweep. You don't want to do what's called a blind finger sweep, where you're just blindly sticking your fingers and they're trying to pull something out. If you can't see it, don't do that. You're just going to push it in further. And so you could use chest compressions to relieve a severe airway obstruction in an unconscious pediatric patient. So remember, if someone's choking and they're unconscious, at that point, you just begin CPR. Okay. Asthma, very common in children. You can have this as a child and outgrow it as an adult. That's fairly common. And so asthma is a condition in which the bronchioles become inflamed and they will swell. Remember, these are the airway tubes in our lungs, and they produce excessive mucus because they're inflamed and irritated, and this will lead to difficulty breathing. So what sound does asthma make? Wheezing. Okay. And so it's true emergency if not promptly identified and treated. And so, common cause for asthma attack is upper respiratory tract infection. So infection can cause this. Exercise, or what we call exercise-induced asthma, exposure to cold air or smoke. So we see this a lot more in the winter months. And emotional stress even can cause these asthma flare-ups. So the sound we will hear is wheezing with our stethoscope, okay? And so in some cases, the airway is completely blocked and no movement is heard. So that's very ominous when that happens. So when the airways get so tight, when we listen to breath sounds on a normal person, we're just hearing air move. Okay, you're hearing air move through the airways, the lungs. And so when it gets so tight, that won't work anymore. And so we call that, the patient's tight or diminished. And so that when you hear that, like when you don't hear sounds, that's incredibly bad. Okay. And so cyanosis and respiratory arrest may quickly develop after this, and the tripod position will allow for easier breathing. Okay, we've talked about what the tripod position is. Also the sniffing position, like you're going to sniff a candle, right? So you take your chin forward, right? That's the sniffing position. And so allow patients to assume a position of comfort. You can administer supplemental oxygen. Now, a bronchodilator via meter dose inhaler with a spacer mask device, if the protocol allows. Remember, if this is your albuterol, right, which is a beta-2 agonist, right, a bronchodilator, we're taking the bronchioles and we're dilating them. So these are known as our beta-2 agonist. The name of this drug is called albuterol. What happens is you've all seen someone's little meter dose inhaler. We showed you these in class. But as a reminder, what a spacer is, it's this device that attaches to where the lips would normally go, and there's a lip port here. So when you press on this, it shoots the mist into this canister and keeps it in this canister so the patient can take several breaths from that canister to try to get all the medicine down into their lungs. And so that's what that is. That's called a spacer device. If assisting ventilations, you'd use slow, gentle breaths. Remember, you don't want to just like bag people really hard because you're going to end up just, especially if they have obstruction, you're just going to end up shoving air into their stomach and then they're going to vomit. It's going to be a problem. Okay. So that's asthma. Remember, we can assist with a meter dose inhaler to help with this. What's that drug called? Albuterol. What's its class of action? It's a beta 2 agonist. It is a bronchodilator. So it relaxes smooth muscle in the bronchioles that have constricted. So interestingly, pneumonia is one of the leading causes of death in children. And it's because, again, they go to daycare and school and get all these nasty viruses and bacteria, bugs. And so, and not only that, their lungs are fairly undeveloped and small. And so, anyways, they can get these really bad infections and it can kill them. And it does kill them. And so it's usually, like it says, often it's due to a secondary infection like, strep pneumonia or Staph aureus or something like that, groupie strep, all these other issues. And so, and it can be viral too, by the way, but, like RSV can lead to bronchiolitis, which can lead to pneumonia. And so just know it's usually secondary to infection. It can also be from chemical ingestion. So you could imagine if someone, accidentally chokes on battery acid, that's extreme, or like, a household cleaning product or something like that, that could lead to pneumonia or pneumonitis, but disease-causing immunodeficiency in children increases the risk. So what does the word immunodeficiency mean, right? This somewhat means someone's immune system is deficient. So their immune system is not really good at fighting off infection. So of course they're going to be at a higher risk of getting pneumonia. The incidence is greatest during the fall and winter months. So the worst months to work in a pediatric hospital is in the fall and winter months because everyone's sick. There is no beds. Everyone's crying. And so, like when I did my rotations in medical school, I accidentally scheduled them in October. And so there was we were just, it was very busy. Every bed was full. And so, again, you don't have to be a radiology expert to realize this is a normal lung over here, right? This is a normal lung. There's the diaphragm. Here's the heart, okay? You can appreciate that this is a little wide over here and this is very wide over here. That's pneumonia. That's infection. That's pus, right? That is sitting over here in the lung, okay? Or even outside the lung. That's like a pleural effusion. But anyways, just know that that's pneumonia. And here's another example. So here's what a normal lung would look, a normal-ish lung would look like. But you can see this area of what we call consolidation. Here it is, and here it is, okay? This thing right here is the heart. But you can see that is infection. And so that is that's pneumonia. It's lobar pneumonia. It's somewhere in one of the lobes. And so the presentation pneumonia is, unusually fast breathing, okay? Sometimes they'll be grunting, okay? So they breathe out, that's grunting, right? They're grunting with each breath. That's to create a positive pressure that goes back into the lungs, so they're self-peeping themselves like CPAP. They're trying to create their own CPAP. And so that's, if you see grunting in children, that's pretty ominous. That means they're really in pretty severe respiratory distress. Nasal flaring, we've covered this. Tachypnea, this is fast breathing. Hypothermia or fever, what? You can see hypothermia in late stage sepsis. So remember, sepsis is the overwhelming infection that has caused widespread vasodilation. And so you can eventually become so shocky in late stage sepsis, you can actually end up with hypothermia, okay? As a quick reminder, what is fever in medicine? It's 100.4 degrees Fahrenheit or 38 degrees Celsius or higher, okay? Must know. So how this will sound when you listen with your stethoscope is you'll have diminished breath sounds, or more commonly you'll get like what we call crackles and rhonchi. And so what is rhonchi, right? That's the sound like I'm taking a straw and I'm breathing into a chocolate milkshake, because this patient's taking a straw and breathing into pus, right? Literally, they're breathing into pus, so it's going to sound like they're breathing into like a thick fluid, because they are. And so you can hear different sounds, rhonchi, rails, it'll sound a little diminished, but just be aware that that's what the noises you'll hear, okay? Rhonchi, interestingly, they left this out. Rhonchi is very synonymous with pneumonia, especially in children. And so the pediatric patient treatment, it's really supportive care. And so you monitor the airway, make sure the airway's open. You might have to provide supplemental oxygen. Remember, we want to keep those SATs above 94%. If the child is wheezing, you would administer a bronchodilator if permitted. You can, because of this inflammation, you can get wheezing with pneumonia. That's actually quite common. And so you would administer a bronchodilator if you hear wheezing. Okay. Bronchodilators like albuterol are beta 2 agonist. Okay. And the diagnosis of pneumonia is usually confirmed at the hospital, usually with a chest x-ray, like what I've shown you. Okay. And so so this is the next thing. This is a viral infection. Okay, so there's a viral infection. And so it's an infection of the airway below the level of the vocal cords, that's usually caused by a virus. Okay, and so the exact name of the virus isn't important, but you'll see this in children from like 6 months to 3 years of age. Okay, and so it's highly contagious. So of course your daycare kids are going to get this. And it has an interesting thing about it. So it starts with a cough, cold, low-grade fever, right, for a few days. And the hallmark sign, can't stress this enough, is stridor and a seal bark cough. So if you don't know what a seal sounds like when they're making their noise, you should go look that up. I'm not going to imitate it. But it's a very distinct screechy sound. And so the reason this is the trachea, the airway below the vocal cords gets swollen. So you can see here that it's swollen. This is the trachea right here. It should normally be like this open line, like here. Here is what's normal. But you see how it comes to a point? We call that steeple sign on an x-ray. And so this is very classic croup. Okay, it's a viral infection. Now, interestingly, croup responds very well to humidified oxygen. So remember, humidified oxygen is where we're just pumping it off the oxygen tree through some bubbly water or saline and giving it to the patient. And so you'll hear parents will say like, oh, the patient sounds so much better after we take a bath or after they're in the shower or after they're in a room with steam, like after the shower or something like that. They sound better. And so interestingly, that is the treatment of croup. Since it's a virus, we can't give antibiotics. And so with that said, very important to know, bronchodilators are not indicated for croup. Okay, so we do not give albuterol for stridor. We give albuterol for wheezing. Okay, albuterol is never given for stridor. It is only given for wheezing. Okay, so very important. Keep that in mind. And we see this clinically. They'll be like, "Well, the child's having trouble breathing, so I gave him albuterol." Well, it's not. That's not what we do. Okay, it's wrong. Now, croup's a problem. It won't kill you. Okay, it's annoying. It's a problem. You might get hospitalized, but it usually won't kill you. Epiglottitis will 110% kill you. Okay, so this is very, very deadly if it's not treated. So thankfully, though, there's a vaccine for this. Haemophilus influenza type B, there's a vaccine that children should be taking to prevent this because it's so deadly. And so this is a bacterial infection of the soft tissue in the area above the vocal cords. So this whole area right here is inflamed and swollen. The most important one is the epiglottis, right? Remember this little leaf-shaped structure that covers the trachea when we swallow. And so what happens is it gets so swollen and inflamed that A, it's very painful, and then B, it can become immobile, or it can get so big it can flop itself over and block the trachea. So, you can imagine the problems this is going to create for a patient. They're going to be very ill. They're going to have an exceptionally sore throat, and they will have a high fever, okay? And so if they tell you the kid's got a high fever and drooling, right, in the tripod position, it's epiglottitis, I promise. Now, thankfully, this is astronomically rare in the real world, but it is not rare on exams. So, I worked at Cook Children's for 2 years. I saw this once, okay? So it's not very common. Again, because there's a vaccine for this. Now, I have seen it assessed to see like what's the difference between like epiglottitis and croup. Remember, croup is a viral infection. Okay, so antibiotics do not treat virals, right? So there's no medicine that we can give for croup generally. And so epiglottitis is a bacterial infection. So we give a very powerful antibiotics when someone has epiglottitis. Now, the hallmark sign of epiglottitis is what I said earlier, is they will have drooling. The patient will not be able to swallow their spit. It'll hurt. So they'll be like leaning forward, just drooling, okay? And so they'll tell you that in exam. So if they tell you a patient has fever and drooling, that's enough to think this is epiglottitis. So like, get a tattoo of that. Fever plus drooling equals epiglottitis. Now, this next one is called bronchiolitis. It's most commonly caused by this virus called RSV, or the respiratory syncytial virus. Okay, and so basically, our lung tissues, our bronchioles, have this thing called syncytium in it. And so basically, what this virus does, if we're looking through a bronchus in a cross section, it can get up into this syncytium and it causes sloughing of the cells. And so you end up with this obstructive pathology. And so we get the bronchioles become inflamed. So we get this diagnosis called bronchiolitis from this viral infection called the respiratory syncytial virus, or the respiratory syncytium virus. And so recently there's actually a vaccine for this for the very young and the very old, okay? And so this kills kids for sure, because their bronchiolitis will get so severe they can't breathe, it'll further exacerbate asthma, they get pneumonia, they get septic, blah, blah, blah. And so this is very, very contagious, highly contagious. And so just through coughing or sneezing, you can get this virus. And I'm pretty sure I had it for 6 weeks straight. And so it can survive on the surface. But thankfully in adults, it's not very severe, like the disorder. Like someone my age, you're gonna not feel well. But in a kid, like a very young, someone less than 2 years, or someone that is very old, this can 100% kill them. And so be aware. Okay, so you'll see this. It's very common. And so this presents with a very hallmark sign, and it's copious secretions, namely like mucus, snotty boogers, just really runny nose, okay? And so that's how it presents. So it'll just be tons and tons and tons of boogers. And so, how you treat this is you suction them, okay? So we take the bulb suction and you suction them very, very aggressively and get all those snotty boogers out and keep their airways clear. Remember, this is going to occur in people less than 2 years of age, and infants are obligatory nose breathers. So if their nose is all stopped up with snotty boogers, then they can't breathe. So they're going to be hypoxic. They're going to have respiratory distress, nasal flaring, grunting, right? Anxious, restless, irritability, inconsolability, those things. And so this is why it's very important to suction a baby's nose. Now, in the history of suctioning babies' noses, they don't like it, okay? So they're going to cry. They're going to be angry with you, but this is what's going to keep them alive. And so, you'll see all the time, the mom's like, well, I tried to suction them, but it makes them cry. They don't like it. Well, your baby also doesn't like dying, okay, and being short of breath. So you have to suction these babies' noses, okay? It's very important to educate the parents respectfully the importance of suctioning their children, okay, their nose. And so this is like a winter, early spring disorder. Spreads rampantly through daycares and stuff, schools. And so the bronchioles will become inflamed, they swell, they'll fill with mucus. And so this is where we get the term bronchiolitis, okay? The airways can become so like swollen and filled with mucus and fluid, they become blocked. They become like plugged, okay, plugged up. Oh, what typically will really hurt these children is dehydration. And so watch for this. These children are often very dehydrated for several reasons. First one is if you're an obligatory nose breather, right, and you latch onto a nipple or a bottle, how are you going to breathe if your nose is stopped up? You're not, right? So they're going to have a hard time feeding and accepting a bottle or a nipple. One, two, all of this copious amounts of fluid that we're talking about, mucus, is made of what? Water, fluids, right? And so they're going to become dehydrated because they're producing a lot more fluid that's going to be lost, right, through suctioning and stuff like that, coughing. And they're also going to be dehydrated because they typically don't want to feed, right? And so it's dehydration is probably actually what would kill or severely harm these infants before hypoxia. You become, because they don't have a lot of reserves, so they become dehydrated very quickly. Okay, so you're going to keep the patient calm, be calm, treat the airway and breathing problems, suction them. You could use humidified oxygen. That is actually quite helpful, right? So for croup and for RSV, which causes bronchiolitis, you could use humidified oxygen. But again, in croup, albuterol is very controversial. So unless they have wheezing, we do not use albuterol, which is the bronchodilator, the beta-2 agonist. Now, pertussis, again, there's a vaccine. This is also known as whooping cough in the United States. Okay, whooping cough. That's what we call it in children. In adults, we call it the 100-day cough. Okay, and so it's caused by a bacteria called pertussis. And so, Borrelia pertussis. And so, what happens is, a kid will get this in school. If you're vaccinated, you don't have to worry about it, but because there's a vaccine in the United States. But what happens is they cough and cough and cough and cough and cough, and when they like finally cough, 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 it's this whooping sound when they're inspiring, right? Trying to catch their breath. They'll cough like 10 times, and they're so short of breath, they go, and then they cough, 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 and they just cough. Okay, and so it's very like annoying disorder for these children. It can be lethal. Usually not though, but it can be. And so the thing to know about whooping cough is if they tell you that there's like, they'll describe this, right? Coughing, 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 and then there's noting, that there's a high pitched stridor during inspiration followed by more coughing, right? That's another way you could describe that there's a whooping sound, high pitched stridor followed by additional coughing, right? And so the infant may develop pneumonia or respiratory failure. And so the thing to know about whooping cough and pertussis is you can get post-tussive emesis. Let's break down this word. So so the tuss is to cough, right? So you can get after the coughing, what's emesis? Vomiting. So after they cough, they can vomit. They can cough so much, it makes them vomit. Okay, that's a very hallmark thing that you will see with pertussis. Now, in adults, you may not get the whole whooping thing, but this is what we call the 100-day cough. They will cough for 100 days, more or less. So what does that mean? Get vaccinated. You don't have to worry about this. Okay? Now, this is contagious, very contagious. It travels through droplets, so you'd want to wear eye protection, a mask, a gown, wash your hands, gloves, stuff like that. Now we're going to talk about airway adjuncts. They really don't change a lot from what we've talked about before, so I'll move through this fairly quickly. We know that the OPAs, or the oropharyngeal airways, are what we put in the mouth. Remember, you start at an angle, you twist while you're advancing it backwards, but you can only use these on patients without a gag reflex. So typically we reserve this for patients that are unconscious. Now, this is a good point. It should not be used in a conscious patient or those who have a gag reflex. So just because someone's unconscious doesn't mean that they do or don't have a gag reflex. So if you drop this into their mouth and they start gagging, you need to pull it out. We also do not use this on a patient who have ingested a caustic or petroleum-based product. So if someone drank bleach, or if someone drank acid, or someone drank gasoline, they would not get an OPA. Asopharyngeal airways, remember this is the one that goes in the nose. If we put two of them, we call it a double barrel. And so you measure this from the tip of the nose to the corner of the mandible or the ear tip, okay, or the earlobe. And so, you could use this on responsive patients because it shouldn't touch the gag reflex area. It's rarely used on someone younger than a year. And remember, we never use an NPA if someone has head trauma or nose trauma, ever. Why is that? You can push it into the brain, okay? Remember, too, children have a very active vagus nerve. A vagus nerve is a parasympathetic nerve, one of the cranial nerves, that runs through the back of the throat, down the esophagus, and into the chest. And so this NPA and OPA and your suction unit, anything that touches the back of the throat or the back throat area can stimulate this vagus nerve. Well, when you stimulate the parasympathetic nervous system, you get low heart rate. And so you can get bradycardia when you do that. So that's something to watch for. If they describe you dropped an NPA or an OPA, and now you notice the patient's becoming bradycardic. When you remove it, the patient's no longer bradycardic. What happened? You're stimulating the vagus nerve. Okay? We've talked about these. So there's several options for the pediatric patient as far as like oxygen. Blow-by techniques at 6 liters are going to provide more than the 21% that we're breathing right now. Remember, the air that you're breathing right now without oxygen is 21% oxygen, okay? For each liter that you add, it's around an additional 3%, okay? So if you give 1 liter, you're now breathing 24%. You give 2 liters, it's 27%. 3 liters, 30%, blah, blah, blah. Okay. And so that's a concept to know. A non-rebreather mask at 10 to 15 liters is around 100% or 95 to 100%. A bag valve mask at 10 to 15 liters provides 100% oxygen because you're taking all the oxygen from the reservoir bag and pumping it into the patient's face. Okay, so it's 100%. What's the other word for oxygen concentration that you could see on an exam? FiO2. Okay, so that means how much concentration you're giving them through your like oxygen delivery device, like your BVM or something like that. Don't have a lot to add on that, but the blow-by method I do want to cover because this is very, very common. And so putting like a nasal cannula or a mask on a kid's face is going to make them mad, like a non-rebreather mask. So sometimes what we'll do is we'll just have the parent hold it close to their face. And that way it's literally just blowing by their mouth and nose to where hopefully they're getting a good chunk of it. That's called a blow-by technique. It's fairly common. Okay. Now, the downside is you're not going to get like the high oxygen concentration, but I would rather have a little oxygen go across the face than none. I would have a little oxygen go across the face than make the child fighting mad and screaming hysterically and kicking and squirming and, fighting. So sometimes, as everything in medicine, you have to weigh the risk versus reward. So sometimes it's better just to give a little blow by and not make the child angry, as opposed to, or not give any oxygen at all. So, you got to know when to hold them, know when to fold them. Some patients will tolerate a nasal cannula. There are pediatric nasal cannulas. We'll show you what these look like in class. They're just small nasal cannulas, so it's just a smaller nasal cannula. Okay? And so this is blow-by. And so, in this particular case, they're using a cup to do the blow-by. You can try that. That's fine. So you just take the oxygen tubing and put it in this cup and try to blow it by. But usually the mom or parent can just hold a non-rebreather next to the patient's mouth like this, okay? And it works really well, okay? That's a pediatric nasal cannula. It looks just like an adult one. It's just a little bit smaller. We've talked about non-rebreathers, okay? It's around 95-ish to 100. It's 90 to 100% oxygen, really. It allows the patient to exhale all carbon dioxide without rebreathing it, so there's that benefit because remember, there's the one-way valve, okay? And so there's benefits in that. And so this is kind of the go-to. If someone has a good respiratory rate and effort, they just need additional oxygen, I'll put them on a non-rebreather. BVM, we've talked about this, so be careful on exams. I see it all the time where students will not choose this as the right answer when they tell you like the patient has like a low FiO2 or they'll tell you the patient's breathing like 20 times a minute and shallow. But that shallow word becomes important. So to make it 20 times a minute and not shallow, you can use a BVM to make them breathe normally. Okay. And so that's a BVM. So watch out when they use words like, oh, the patient's breathing shallow or ineffectively, or, they'll throw in that one word. It's shallow, ineffective, rapid, something like that, then you should think, oh, I might need to support the quality of their ventilations with a BVM. Okay. Non-rebreather mask and a BVM. Now, one thing I'll say with a BVM on a child is it's difficult because usually they don't have very large chins and noses as adults do. So it can be a lot more difficult to get a face seal. One. Two, you want to make sure that you don't have an air leak that pushes air into the eyes. This can cause pretty severe damage to the eyes if you end up compressing the eyes with the mask or if you start blowing air into the eyes. Okay? The two-person bag mask ventilation technique. So we've talked about this. This is where one person's doing like a double CE and the other person's ventilating. Okay, it's usually more effective at a tight seal. So this is definitely the way I prefer to do it if I have enough hands back there to help me. Now, cardiopulmonary arrest, again, we've covered this in BLS CPR class, but children are affected differently by decreased oxygen concentration. What happens? Hypoxic children die. Okay. And so their heart will eventually slow and they will become bradycardic. Remember, bradycardia is the word for brady is slow, cardiac, so slow heart. So the heart rate less than 60, would be bradycardia. And so that cardiac arrest would be imminent at that point. Okay, so they're going to go into cardiac arrest. Now, shock, this should be a review, by the way. That's why I'm kind of moving through these. Uh, shock's defined as hypoperfusion. The cells are not being perfused. And so shock develops when the circulatory system is unable to deliver a sufficient amount of blood to the organs, okay? And so it results in organ failure and eventually cardiopulmonary arrest, okay? They're going to go into cardiac arrest. And so decompensated shock, compensated shock is the early stages of shock. So the body's still compensated. So signs of compensated shock would be, maybe an elevated heart rate, anxiety, elevated respiratory rate. Okay, decompensated shock is a late finding in shock and rather ominous. It's much more difficult to reverse. And a finding in decompensated shock would be hypotension when the blood pressure starts dropping. That is definitely decompensated shock. So common cause of shock in children is trauma injury with blood loss, dehydration. Okay, so this would be hemorrhagic shock. This would be hypovolemic shock. Severe infection, this is sepsis, also known as distributive shock. Neurologic injury, also known as neurogenic shock, which is also a form of distributive shock. So distributive, hemorrhagic, or hypovolemic and hemorrhagic shock. Okay, so do know those different types of shock. We're going to talk about them, but common causes would be like anaphylaxis would lead to distributive shock. Remember, all the vessels in the body become leaky, so you end up with fluid leaking out of the vessels into the third space. That is known as distributive shock. Why is it distributive shock? Because you've distributed the fluid to the wrong area. It's in the third space, okay? Diseases of the heart. So, I tell you kids die of hypoxia, and that is true, but there is, a very rare amount of children that have heart defects, and so they could have, valve issues or vessel issues or a very large heart or holes in their heart and all these heart issues that happen in children that could lead to shock. Okay, so that would be a form of cardiogenic shock. Okay, tension pneumothorax. What type of shock is that? That is obstructive shock. Okay, it's when the collapsed lung starts pushing on the great vessels in the heart, obstructing the amount of blood that can go in and out of the heart. That's an obstructive shock. Because of fluid around the heart, that's called cardiac tamponade. Okay, cardiac tamponade is, again, a sign of obstructive shock. What is the signs of, we call it Beck's triad, right? And so that would be jugular venous distension, muffled heart sounds, and a narrowing pulse pressure. What else? Pericarditis. Pericarditis is an interesting diagnosis. It can be viral in nature, so you do see this in children. I've seen it in children several times. And so pericarditis is, remember, the heart's surrounded by the pericardium, okay? Well, that sac can get inflamed, and it can also be infected by a virus, namely Coxsackie virus is what it's called. And so you can get a viral infection that it causes pericarditis. So imagine the lining of the heart sac becomes inflamed. What happens is the patient will have chest pain. But interestingly, this patient's chest pain is relieved when they lean forward. So pericarditis has a very hallmark sign. And if the patient tells you their chest pain is better when they lean forward, it is probably pericarditis. Why is that? The heart sits in my chest like this. And when I lean forward, it's lifting up off of, and now it's no longer rubbing. Okay, so when I lean forward, it's not rubbing. And so it's able to beat and not rub on this inflamed pericardium, okay, and the sac as well. And so that's the idea. So you might even see the patient walk into the come walking to you leaning forward because they know if they lean forward, it hurts less. That is pericarditis. It can be caused by a lot of different reasons. The most common one in children, though, is going to be a virus, okay, called the Coxsackie virus. Not making that name up. Now, the shock in pediatric patients respond differently than fluids to fluid loss. So children have much less fluid reserve, okay, and so also, children are less likely to be able to clamp down their vessels like adults can. So the way they compensate is with increasing their heart rate to increase their stroke volume. What? Okay, so when someone goes into shock, an adult, we would typically see the vessels try to clamp down to increase afterload. Okay, that's the amount of pressure that the left ventricle has to pump to eject blood out of the left ventricle. And so that's what normally happens. The vessels should squeeze down. But in a kid, those vessels are not very mature, so they can't squeeze down very well. So in order to maintain cardiac output and stroke volume, right, what happens is the heart rate will increase. So what I'm trying to stress is in kids, one of the first things you'll see in shock is an increased heart rate. Okay, their heart rate is what will increase. That's one of the few mechanisms they have to maintain cardiac output, is to increase the heart rate. So we call that tachycardia, fast heart. They could also have increased respirations. We call that tachypnea. They could also have show signs of pale or blue skin. We call that cyanosis, is blue skin, and the pale skin is called pallor. Signs of shock in children, I just talked about this tachycardia, poor capillary refill, mental status changes, okay? We treat shock by the XABCDEs, you know. So the order becomes CAB, which is circulation, airway, breathing, if obvious life-threatening external hemorrhage, or if cardiac arrest is expected. I don't know about that. If there's an obvious external hemorrhage, you would stop the bleeding first. But yeah. Remember, I say this all the time. Blood pressure does not fall until shock is severe. That is decompensated shock. You are on your way to dying when that happens, especially in a kid. So limit your management to simple interventions. Do not waste time doing a bunch of nonsense in the field. Remember, take the patient to the hospital. Make sure the airway's open. You might have to provide artificial ventilation using a BVM. Control the bleeding. Give supplemental oxygen. Sometimes this is done by blow-by. Monitor the airway. Keep the patient in a position of comfort. Keep them warm. Use blankets. Transport them. You may need ALS intercept. So there are drugs that paramedics can give, and like IV fluids and stuff that might be able to help the shock patient. Okay, but most importantly, they need to go to the hospital. Now, anaphylaxis. Anaphylaxis is fairly common in children because they didn't know they had an allergy. Okay, so you got to find out once. And so this is an example of anaphylaxis. What do we call this rash down here? What's this rash called? Call those hives or wheals, right? Urticaria is the medical word for hives. Okay, remember that word. Urticaria equals hives. Okay, now look at this kid. That's hives, 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 hives. His face is all red, and see how his eyes are all puffy and swollen? That's anaphylaxis. Now look at this kid's face. His lips and mouth are all swollen. This can swell so much that he can't get air down into his airway, and so he can end up with an airway obstruction and die from this. That is one of the many ways you can die in anaphylaxis. And so, this is why promptly addressing this or noticing it and treating it is important. And so anaphylaxis is the life-threatening allergic reaction that generally involves multi-system response. Okay, so you'll get the airway swelling. We call that orolingual angioedema. Okay, dilation of the blood vessels, so we can get a form of distributive shock. Okay, remember this is where the vessels dilate and the fluid in the vessels will go into the third space. The common causes in children are going to be insect stings, medications like penicillin, food allergies like maybe nuts or peanut butter or something like that, dairy. Those are all possible causes. So the signs and symptoms of anaphylaxis is going to be hypoperfusion, also known as shock, stridor, and or wheezing. You could have both. Remember, with this upper airway swelling, you're going to have stridor. Okay. With this lower airway swelling, you're going to have wheezing. So you could actually have both with anaphylaxis. So yes, you would give albuterol in this case. Yes, you would give epinephrine. Yes, you would give Benadryl. Yes, you would give steroids if you could. Okay, and so the increased work of breathing, restlessness, agitation, sometimes a sense of impending doom. Okay, and remember, the medical word for hives that is used in exams is called urticaria. They're the same thing. So the treatment, of course, keep the airway open, position of comfort, don't irritate them. You may have to inject an epinephrine pen. Remember, for children, we use half the dose. The dose is now 0.15 milligrams of epi. Okay? And remember, in adults, 0.30 milligrams for an adult. And so be aware of that. This is where you would use the epinephrine. Remember, epinephrine, you remove the safety cap, you would prep the skin on the lateral thigh, which is the outside thigh, and you would inject this, hold it for 10 seconds, and remove it. This will save their life. Now, one thing I want to point out, okay, this is a trainer, and these two are real epinephrine pens, EpiPens. Why do you think there's two EpiPens? It's because the half-life of epinephrine small. It's like 5 to probably 15 minutes, and at the most. And so I am. And so what's going to happen is, yes, that first epinephrine pen, they may get better. But then 15 minutes later, they're really sick again. They're swelling again and having wheezing. So then you would have to re-inject them. So it's not uncommon to have to re-inject this in about 15 minutes, 10, 15, 5, 10, 15 minutes. You might have to re-inject them. We've talked about hemophilia, but this only happens in men. Okay, remember? X-linked X-linked recessive. So it can pretty much only happen in men. And so that's an important thing to know. And so it's usually hereditary, and this is quite severe. And so the problem is they lack the normal clotting factors. And so sometimes they can even just bleed spontaneously, especially into a joint. We call that hemarthrosis. And so their like knee joint will just get really big and red, and it's because they're literally bleeding and bruised because it's just bleeding into the joint. And so that's an issue when that happens. And so I actually know a guy who has a kid that has hemophilia, and uh, and so you would hear stories of like the kid would bite his tongue, and they have to go to the ER to get these clotting factors because the tongue would just bleed and bleed and bleed and bleed and bleed, and so that's uh, uh, the issue with hemophilia. So any type of bleeding, whether it's, I mean, literally, guys, like a paper cut or biting a tongue, pretty minor things, uh, can turn into life-threatening bleeding because it will continue to bleed. Your body lacks the normal clotting factors to get that to stop bleeding. Whoops. So we've talked about the AEIOU tips mnemonics. So remember, these are causes of altered mental status: alcohol, epilepsy, endocrine, electrolytes, insulin, opiates and other drugs, uremia, which would be kidney failure, trauma, temperature, infection, poisoning, psychogenic causes. Psychogenic meaning like it's a psych issue, like they may be faking it. Shock, stroke, seizures, syncope, space occupying lesions like a neoplasm, brain tumors, subarachnoid hemorrhage, that's a form of a hemorrhagic stroke. And so, these are all things that might help you guide when someone's altered. The list is, there's much more than that, but those are some of the things that you might consider on an exam or in the field, even when assessing an altered mental status patient. Because altered mental status is a very, very common complaint. Again, the brain is very perfusion dependent. If it doesn't get exactly what it needs, it stops working. And so just keep that in mind. Now, seizures, these are fairly common in children. And so seizure is where you're having unorganized electrical activity fire across the brain. So sometimes it's the whole brain. We call that a generalized seizure. Sometimes it's a small part of the seizure. We call that a focal or a partial seizure. Sometimes it's very small and you don't see a lot. You'll just see like lip smacking or eye blinking, right? That would be an absent seizure. So there's different types of seizures, okay? But this happens in a lot of different ways. And so it can be subtle in infants to where they may just have a weird gaze or flicking of the eyes or something like that, or a weird sucking or like smacking pattern, or like a bicycling motion that seems odd. And so, again, the kid can't raise his hand like, hey, bro, I just had a seizure. And so sometimes these are not diagnosed or improperly diagnosed or missed, you know? And so, common causes of seizure would be a head trauma, right? So, so if someone's seizing, you should very adult or female, you should be or I'm sorry, adult or child, you should be looking for child abuse. One, two, electrolyte imbalance. Specifically like something like sodium. It should be a lower case A. Potassium, of course, magnesium, chloride, calcium, all those things. If they get out of whack, namely sodium, you will have a seizure. Fever, we're going to talk about what a febrile seizure is. Hypoglycemia, okay, low blood sugar. What's the normal blood sugar range? Somewhere between like 70 and 120 is what's normal. So if someone has a blood sugar of 44, they could have a seizure, okay? Infection, ingestion. What's ingestion? That's someone that swallowed something. So like a pill or like a toxin or something like that. Hypoxia, also known as lack of oxygen. Medications, poisonings, seizure disorder like epilepsy, very common in children. Recreational drug use, okay? Head trauma, and sometimes it's no cause can be found. We call that idiopathic, okay? And so once the seizures stop and muscles relax, it is referred to as the postictal state, okay? So watch for that. And the thing about the postictal state is their body, especially if they had a generalized seizure, just ran a marathon, so it's going to be tired. And so not only that, while they were seizing, their diaphragm was not working effectively, so they were not breathing effectively. So they may have hypoxia. And so a lot of times I would like to put like some oxygen on these patients because they're usually hypoxic and usually even cyanotic after a seizure. And so the longer and more intense the seizures are, the longer it will take for this imbalance to correct itself. And so you'll see this actually in the real world. Someone that had a 1 minute seizure may take 5-10 minutes for them to come back to somewhat normal where they can converse. But someone that had a 10-minute seizure, it may take 30 minutes for them to come back out of the postictal state. And so, of course, the longer the state of the seizure, the greater, the more significant the postictal state will be. Okay? And we just find the postictal state is over once the normal level of consciousness is regained. Now, a true life-threatening emergency is something called status epilepticus. Status epilepticus is a true life-threatening emergency. And so these are seizures. There's two ways you can diagnose this. Seizures that continue every few minutes without regaining consciousness, okay? Or they'll say, the other way they'll word this is seizures without a lucid interval. So if you're lucid, you're conscious, right? So they'll say seizures without a lucid interval. So they'll say that means seizures without an interval, a point of time where you're with it, you're lucid. Or a seizure that lasts longer than 30 minutes. I have seen both in EMS. I had a lady seize once for like 40 minutes. And the only reason she stopped is because we stopped her. And so just keep in mind, so that's status epilepticus, a true life-threatening emergency. Why is that? The body becomes very hypoxic during this, and it's using a lot of energy to do the seizure itself, okay? And you're not breathing effectively during a seizure. You can also vomit during a seizure and have aspiration where you choke on your vomit. So there's a lot of risk with status epilepticus. It can cause irreversible brain damage from the firing, okay? It's a bad deal, status epilepticus. Now, recurring or prolonged seizures are life-threatening. I just said that. If the patient does not regain consciousness or continues to seize, protect him or her from harming themselves and call for ALS backup. Why is that? Because paramedics can give a medicine through the IV or through the muscle or through the nose that will have them stop seizing. We calm their brain down, their muscles down. And so we just protect patients that are seizing. You never hold down a patient. You never put something in their mouth. You don't hold them down. You just move stuff out of their way. If you can, you might try to put some cushioning up underneath them or something like that. But you don't hold them down, ever. Securing and protecting the airway are the top priority. Like I said, these patients can vomit or even just choke on their saliva, okay? And so you really have to worry about that. So, always have your suction out and ready to go for these patients, especially in the postictal state. As soon as they stop seizing, I'm shoving that yonker in their mouth and suctioning it, whether I think they need it or not, because it's probably filled with blood. Also, it's not uncommon for seizure patients to bite their tongue. And so they can be choking on the blood from their biting their tongue, or they'll bite their cheek. I've seen seizure patients bite chunks of their tongue completely off. And so that's not uncommon. And usually, almost always, I'll put these patients on a non-rebreather. Okay. Now, if they tell you that the patient's not improving with a non-rebreather, their SATs are very low, or their respirations are shallow, or whatever, then use a BVM. Now, sometimes, and I've seen this in the field, if like the patient has a known history of seizures, the physician will prescribe something called Diastat. And so this is diazepam, which is a benzodiazepine like Xanax, that you can put in the rectum. Okay. And so in a kid, you can look at this. You can have them, you can like pull down their pants and you put this in the rectum, right? Like the medicine, and you inject it. And then you would So you expose the butt cheeks, put it in the rectum, and then you would push the butt cheeks together to try to keep it from leaking out, or then pushing it out. And then because the rectum itself is extremely vascular, and so the way this medicine is formulated is to be picked up by that mucosal tissue, and it works very well, and it'll stop their seizure. Okay, so this is called Diastat. Okay, it's a trade name, but this is what it looks like. It's like and it's usually kept in the refrigerator, so the parents will keep it. It needs to be kept cold, and so when you pull this cap off, there's already like lube on there, and so again, you would open up the kid's butt cheeks. This would go into the rectum, not the vagina, but in the rectum. You would inject it, and then you sometimes you need to keep the butt cheeks together to keep it from falling out, and that's kind of how you do that. Now, ambulances don't carry that, but a lot of times the parents will be prescribed that from the pharmacy. And like I said, it's kept in the refrigerator. Okay? Now, this next condition I've talked about a lot, but we'll talk about it some more. It's called meningitis. So remember, we have these surroundings around the brain and the spinal cord, the central nervous system, called meninges. And these can become inflamed by bacteria, virus, fungus, parasites, right? Several different ways, and become inflamed. And this inflammation can become very severe and it can kill you. This is actually, as you can imagine, if there's pus sitting around your brain and bacteria, this could kill you. And so, not good. This can also cause brain death and all these other issues. Brain damage, death, okay? And so, this is showing you a picture that's all blurry. Here's the skin, here's the skull. And remember, going deep, it's a DAP, right? So it's the dura mater, arachnoid matter, pia mater. If you're going this way, it creates a pad for the brain. So it's the pia mater, arachnoid matter, dura mater. I don't care which one you use, but you do need to know those layers. Okay? The dura mater is a thick, leathery-like substance. It's not thick, it's fibrous. Better word, it's thin. So individuals at greater risk of meningitis is interestingly males. Newborn infants, group B strep would be a very severe or a very likely cause of this in an infant. Of course, if you have an immune system compromised by AIDS or cancer or an organ transplant or something like that, you're at a higher risk of meningitis. If you've had a history of brain, spinal cord, or back surgery, you're at a higher risk of infection of those meninges. If you have had head trauma, you're at a higher risk of meningitis. Or if you have if you've had like a shunt placed or pins or other foreign bodies in the brain or spinal cord, what's a shunt? I'll show you. A shunt is a tube that will go from like here and go all the way down, and it'll drain into the patient's abdomen, excess cerebral spinal fluid. And so sometimes, for whatever reason, there's several reasons, they'll have excess, the child will have excess cerebral spinal fluid. So how we treat this is we just drain it. And so it just drains into the abdomen. Well, as you can imagine, there is a potential for bacteria or fungus or viruses or protozoa to infect this tube in the shunt. So that's called a shunt. So what are the signs and symptoms of meningitis? Fever, altered mental status. They may or may not have a seizure. Okay, and infants younger than 2 to 3 months can have apnea, cyanosis, fever, a highly distinct high-pitched cry. It's because of how much pain they're in, and or hypothermia. What? Hypothermia? Again, like I said previously, in sepsis you can have fever. That's what's more common. But in late-stage sepsis, you will have hypothermia. You will have a low temperature. Okay. It's like a little picture just to show like what will happen. This is all pretty makes sense. Oh, and remember, you'll have the bulging of the fontanelles. Remember the fontanelles, the soft spot of the baby's head? If those haven't fused yet, they can be bulging. Okay, so it's kind of sticking up. This is a common thing too. Photophobia, vomiting is common, refusing to feed, stiff or rigid neck. Remember, we call that nuchal rigidity. You can have a skin rash. That's the next slide. I'll show you what this looks like. Or it's the next slide. And so remember, meningitis means meningeal irritation or meningeal signs, right? And so, or meningitis means inflamed meningitis. And so we're going to see this irritation of the meninges. And so when the brain and spinal cord lining get irritated and inflamed, it's going to hurt to take your chin and touch your chest, right? You should normally be able to do that. But a patient who has meningitis will not want to do that because it is going to stretch out these meninges and they're not going to want to do that. So there's these two signs that I don't really think you need to know the names of these, but I'll have you know, um, there's this thing called Brzezinski sign, where when you take the patient's head and go like this, they're laying flat on an exam table or a bed, they're going to bring their knees up to try to pull pressure off of the meninges, okay, of the spinal cord in the brain. So if they do that and it's positive, it's Brzezinski sign. Now Koenig sign is very similar. So they're going to resist you when you're trying to extend or like bring the leg up while it's hip. Well, extension of the leg while the hip is flexed. So while you're bringing this up, they're going to resist that because again, it's you can imagine there's fibers in here. It's it's pulling on the spinal cord, and so as you're pulling on these inflamed things, it hurts. So they'll resist that. Okay. Now, Neisseria meningitis is the most common cause of meningitis, really in adults, but children it's group B strep, followed by there's a virus. I think it's Coxsackie, and so yeah, group B second and Coxsackie. And anyways, the third one would be Neisseria meningitis for those that are less than 3 years of age, and so Neisseria meningitis is very common in like dorms and in the military and stuff like this. It used to be, but now there's a vaccine for this. So if you're in college, you've had to have the meningitis vaccine. In fact, if you're in this program, you've had to have it. And so you don't want uh, this bacteria. It can kill you. And so it's probably the most common. This is probably the most lethal one of the bunch that I could think of. Maybe one of the fungal ones would be more lethal. Maybe not, actually. This one's very lethal. Okay, and so Neisseria meningitis is what you'll end up with is rapid onset meningitis symptoms. And so this will lead to shock and death because it's going to lead to sepsis. Okay, this will become systemic, right? You'll get bacteremia, which is bacteria in the blood. And so you'll end up with, systemic organ failure, sepsis type issue. And so children can present with this hallmark rash where you'll get these small pinpoint cherry red spots, or you could get these large purplish black splotches, and so this is what it looks like. And so but what's annoying is you can see the same rash in strep throat. And so, but just know that this is a rash that children could get. So, if they go a step further in an exam and they tell you, kid has this high pitched cry and fever and vomiting and bulging fontanelles and neck stiffness, and they also have this rash, right? They're really trying to push you. This is meningitis. But interestingly, Neisseria meningitis is the only one that I know of that creates this type of rash. But in the context of meningitis, but again, you can get this rash after having strep throat. Okay, you can get this rash after several viral infections as well. This type of rash. So you can get this for a lot of reasons. It's not specific. Now, meningitis is very contagious. Okay, and so I would wear a mask, glove, gowns, eye protection. Spread through droplets, and so be very careful with meningitis. Now, the treatment is going to be supportive, but you might have to give supportive ventilations if needed, right? Oxygen, and reassess the vital signs frequently. Okay. Geez, I feel like this chapter doesn't end, does it? Are we getting towards the end? Yes. All right, 63. Almost done. I need a break. Never take a complaint of abdominal pain lightly. This can be a life-threatening emergency, especially in kids. You can get like a intussusception or a midgut volvulus or something like that, and so this can actually be a big deal, but it could also just be constipation, or it could just be a stomach bug or something like that. So you do have to take these seriously. This is why they pay doctors the big bucks to figure out what exactly it is. But don't dismiss any of these diagnoses because they're serious. Okay. And so complaints of GI origin are common in pediatric patients. My tummy hurts. It's pretty common, but we still need to take them seriously, okay? Don't take them lightly. And so in most cases, patients will experience abdominal discomfort, nausea, vomiting, diarrhea, right? Those are prodromal symptoms, right? This happens in a lot of GI issues. Now, we've talked about appendicitis. I've had appendicitis actually as a kid. I was in 6th grade. And so appendicitis is, if you have like this is the rectum, right? And so what happens is an appendicitis, there's this little pinky, this is the colon I'm drawing. This is inside a patient's stomach. So this is the ascending, transverse, descending colon, sigmoid rectum. And so what happens is the appendix sits over here in the patient's right lower quadrant at the end of or at the beginning of, I'm sorry, the large intestine, the colon. And so it's this little pinky shaped structure, and sometimes poop can get stuck, what's called a fecalith, can get stuck right here and block off this tube. Well, when this gets blocked, it'll become inflamed and swell and eventually become infected. And we call that appendicitis. And so this can rupture. It'll get so inflamed and large, it can rupture. That would lead to peritonitis, right? And so you'd have gut and poop spilling into the guts. That's a problem. And or not. You could just have right lower quadrant pain. So remember, there's a few tests we can do to test for appendicitis. The first one is rebound tenderness. So remember, the patient's pain is going to be over here in the right lower quadrant. That's where the appendix is at. It can also be located, the pain can be located around the umbilicus, the belly button. So what you do for rebound tenderness is you will go over to the left lower quadrant and push down and quickly lift up. So it goes like this and lift up. What's going to happen is not necessarily the pushing down is what hurts. It's when you let go. That rebound tenderness is specific for peritonitis, which could indicate appendicitis. One. Two, you could do the heel drop test. So you have the patient stand on their hippie toes and then pop down on their heels. And when they do that, that pain is going to get shot up into the peritoneum, that energy will, and it's going to cause pain. So that's a fairly accurate test. Typically, when the patient walks, they're going to be hunched over, so they're not stretching out their peritoneum. And so this will almost always present with nausea and vomiting. This is treated surgically. So the patient will go to surgery. A surgeon will come in here and chop this off and remove it, wash it out. You're out of the hospital the next day. So we've talked about this in the OB chapter, in the neonate chapter, but remember, we asked things like um, how many wet diapers have they had? How many ounces of liquid have they taken today? Are they keeping fluids down? Oh, they're vomiting. What does their vomit look like? Oh, it's just green, which would be bile, or it's not. It's just stomach acid, or it's Gatorade colored. I don't know. These are all things you would ask. How many times had the patient had diarrhea today, and for how long? How many days? Oh, they've had 10 diarrheas for the past 5 days. Yikes, that's bad. Oh, when the patient's crying, are they having tears, right? You can get so dehydrated that the patient, when they cry, they're not even shooting out tears. You could look in the patient's mouth. Is their mouth dry? Um, Poisoning, this would be common. Again, kids put everything in their mouth, right? Now, it can occur by ingesting, inhaling. Injecting would be pretty rare for kids, but I guess it's possible. Absorbing toxic substances. So common sources, these are going to be household products like, alcohol, aspirin, or acetaminophen. Um, Acetaminophen's the generic name of Tylenol. Cosmetics, so like lotions and hair dyes and all that stuff. Household cleaning products, Lysol, bleach, fabric softener, all those things. Household plants. There are plants that are toxic to children. And so be aware of that. Now, continuing this, iron is a very, very, very toxic thing to babies. And so, like, this is the problem with like my delicious Flintstone gummy vitamins that I take. They have iron in them, and so kids could mistake that for candy and eat the whole bottle. That would be iron toxicity, and that can cause liver damage and kill you eventually. And so, prescription medications. Obviously, kids think that they're candy, so they start chewing on them. Illicit street drugs, obviously. Vitamins, very common for kids to overdose on vitamins, especially like the sweeter tasting ones. So, it's going to depend on what the kid ate. Who do you call for a poisoning? Remember the poison control. I think the number is 1-800-222-12222. I think that's the number. Poison control. Okay? So be alert for signs of abuse. You know, um, After the primary assessment, you could ask the following questions, right? What is the substance involved? How was it ingested? Did they swallow it all at once? Did they do this over a period of hours or days? Uh, what time did the incident occur? When was this discovered? When did the symptoms begin? Any changes in the level of conscience or behavior? Any choking or coughing after the exposure? Has this ever happened before? So another technique, if it's like prescription or something like that, you could count pills. So if it was filled 2 days ago for a 30-day supply, and 15 pills are missing, you may think, well, they've ingested at least 13 pills. And so we do that a lot of times. You'll count pills, okay, to figure out what's missing. So again, who do you call? poison control. And then other than that, it's really kind of supportive care. Now, you can do activated charcoal if your system allows it. And so remember, activated charcoal is a highly porous substance that has a great surface area that will absorb products that are non-petroleum or alcohol based. So you could give this to someone that overdosed on aspirin or overdosed on whatever. As long as it's not like petroleum based or alcohol, it'll work. And it's within the first, I think, 30 minutes to an hour of ingestion. So you couldn't give this activated charcoal to someone that ingested something 2-3 hours ago. It's not going to work. It's already too far gone and absorbed. Now, activated charcoal tastes disgusting. So if you give it to a child, you're probably going to have to conceal it in like a bottle with a straw and have them drink it that way. When I worked at the pediatric hospital, we would mix activated charcoal with like a Diet Cherry Coke or something. And we would just give it to them in a straw, and we'd trick them, and so that's how they would take it. So it dehydration. Again, they don't have a large fluid reserve, so this is the thing you have to worry about with children with the nausea, vomiting, the RSV, the mucus production. All that they're not eating, they're not feeding. The dehydration is what's going to cause their problems. Probably, like this is more likely what will kill them than anything else is dehydration. Or cause severe effects for them. Hypoxia will kill them too, but this is a very serious issue. Right next to hypoxia, these are probably equal. And so vomiting and diarrhea are probably the most common causes. Infants and children are at greater risk. Again, they don't have a reserve of fluids, and it can be mild, moderate, or severe. And so mild dehydration, we've all been there and probably here right now. Dry lips and gums, decreased saliva and wet diapers. Okay, so you're going to see less wet diapers. Now, moderate dehydration, this is where you really need to start worrying, is sunken eyes. So the eyes will seem sunken in, like they're pushed back. Sleepiness, irritable, loose skin. There's a picture coming up. But remember the skin turgor test, where you can take the skin on the top of the hand and pinch it together and form a tent and let go. In a hydrated person, it'll go right back to normal. But in a dehydrated person, it'll stay tinted. I'll show you what that looks like in babies because we check it on their scalp on the next slide. And so also sunken fontanelles. So the fontanelle should be flush with the skull, but if you notice they're severely sunken, it's because they're dehydrated. Okay. Now, severe dehydration would be mottled, cool, clammy skin, delayed capillary refill, and increased respiration. So this would be very, very bad. This is approaching fatality. And that is tinting of the skin. So this test is called skin turgor test. And so you can pinch skin, like in a baby, you can do their scalp, but in adults, we typically use the top part of the hand. And so since that skin has been so depleted of its fluid, it's lost some of its elasticity and its volume to where it's going to stay tinted. Last few slides, this one's very important. So I've talked about what fever is. It's 100.4 degrees Fahrenheit or 38 degrees Celsius or higher is abnormal. We call that fever. I don't care if it's 100.1. I do care, but it is not fever. So just be aware of that. Fever is 100.4 or higher. Okay. Oh, my baby runs low-grade fevers. There's no such thing as a low-grade fever. It's 100.4 or higher. Okay. And so now fever itself isn't truly life-threatening. It's what's causing the fever, like meningitis or something like that. That could be life-threatening. Now, the causes of this could be infection, clearly, meningitis, bronchiolitis, stuff like that. Also, status epilepticus. What? So think about it. If someone seizes for 30 minutes, do you think their body's going to get hot? Yes. So they will always be hot. When you have prolonged seizures, your body's going to get hot, hyperthermic. Okay. Also, cancer, sure, especially cancers of the hypothalamus, like in the brain, sure. Also, certain cancer drugs can cause fever. Drug ingestion, interestingly, aspirin. This is one of the known things and same with Benadryl. You can get very hot when you overdose on these drugs. Okay. Now, arthritis, I think it would be rare. So SLE, which is lupus, this is an autoimmune disorder that doesn't really happen in children. I mean, it can, like teenagers, but interestingly, it has what's called a malar butterfly rash, to where they'll have a rash across their nose and cheeks and sore joints. They could also have discoid rash, where it's like lupus means wolf, and so they used to think that wolves would bite people in the middle of the night, and so That's why it's called lupus. And so, anyways, they could have like a almost like a bite, like a rash on their extremities or on their body. Very rare. I'm not going to test you on that. High environmental temperature, of course, could lead to fever, so per se. Okay. So the results of internal body mechanism in which heat generation is increased and heat loss is decreased can cause fever. And so the acute body temperature is important for pediatric patients because two things. When we assess this, we assess it rectally in children less than a year of age. Really, 6 months to a year, you'll assess it rectally, but over that, we don't assess it rectally. Okay, so like definitely if they're over a year, we don't assess it rectally. You can just do temporal artery scanner, orally, axillary, tympanic membrane, pick one. Under the arm or what I just described will work for older children. Now, the patient may present with signs and symptoms of shock, right? So stiff neck would mean meningitis, a rash could mean a lot of things, hot skin, flushed cheeks, bulging fontanelles, right? That again, bulging fontanelles would be meningitis. How many times have we said that, right? So you should be aware that know that. Transport and you would manage the ABC. So usually it's supportive care. And so, you could give, some places will allow you to give Tylenol. Sure, you can. But we don't try to aggressively lower the temperature of these patients because of this. Febrile seizures. So if someone has fever in the hospital, we say that they are, like if I'm talking to like another medical student or to a doctor or to a paramedic, I'll say the patient is febrile, right? Meaning they have fever. Okay, so if I say my patient is febrile, it means they have fever. If they're non-febrile, it means they don't have fever. And so we use that slang. It's not even slang, it's the medical term quite a bit in medicine. And so it can there's this disorder called febrile seizures. So if you break down the word febrile seizures, it literally means fever seizures. Okay, and so that's an important thing to know. Oops. Wow, that's pretty bad. Let's try that again. Fever seizures. And so this only happens in a set range of children, and it's 6 months to 6 age. So I don't care if they're 7 years old. They don't meet the diagnostic criteria. It's something else. Okay? So febrile seizure only happens between 6 months and 6 years of age. If you don't believe me, look it up or go talk to a pediatric neurologist. I've done both. And so that is the criteria. Now, this is caused by fever, obviously, hence the name. And so it typically occurs on the first day of a febrile illness. So like, oh, baby's got a middle ear infection and now they have fever. Not baby, 1 year old has like a middle ear infection. Now they have fever. Okay. And so what happens is they'll have this tonic-clonic seizure. So it is a true seizure, abnormal electrical firing across the brain, and they're going to have a seizure. Now, it should last less than 15 minutes with little or no postictal state. 15 minutes is astronomically long. I've never seen one last that long. But it can last several minutes, 3 to 5 minutes. And remember, a parent watching their child seize, it feels like an eternity. So be aware of that. Okay, and so the thing is, the febrile seizure isn't necessarily like a neurological emergency. This doesn't mean they have epilepsy. This doesn't mean anything bad. So typically when we see febrile seizure, we're like, okay, that's a problem. Patient needs to be seen by a doctor. But it's not like a lights and sirens to the hospital type deal, right? It means, they need to go to the hospital. They need to be seen. Something is going on, okay? But it's not like a new onset seizure of like if a 12-year-old boy had a new onset seizure. That's very concerning, right? That's not normal. And so be aware of that. Now, the treatment for this is sometimes the thing about a febrile seizure is they say what causes this is how rapid the increase in temperature is. So it's not necessarily that the temperature got up to 103.2. It's the fact that it went from 98.8 to 103.2 in an hour and a half. That sudden change is what will trigger these febrile seizures. And so sometimes that temperature can get so high, I've seen it in the 104s, that you need to cool them with tepid water. So you might try to cool them with water and fanning them because if their temperature stays high, they could continue to seize. Now, you don't want to cool them so aggressively they start shivering and you have problems with that, but you do want to cool them. So you'd remove their clothing and you might put a little bit of like water on there and fan them to try to cool them. Okay. Now, this isn't an emergency, and so not an emergency. They do need to be seen in the hospital setting. Why is that? Something, whether it's a middle ear infection, which we can treat with antibiotics, or a virus, or strep throat, or whatever, has caused them to have this seizure, and we need to fix whatever that is, or it needs to be at least assessed and identified. And so, uh, I just can't stress enough. This isn't a neurological emergency, right? But it is a medical issue that needs to be seen by a doctor. Okay, so do encourage these patients to go to the hospital. That's it for this video. I appreciate y'all's attention. The last one talks about trauma, and then we will do the review questions.